Hello, I'm Dr. Ajay Gokul, Senior Resident in the Department of General Surgery with six publications into my credit. And today we'll look into the acute and chronic inflammatory conditions that we deal with in general surgery. Today's learning objectives will be soft tissue infections that involve the skin, subcutaneous tissue, fascia, and the muscle, classified as acute or chronic based on the duration and process. And we'll discuss about the causative organisms, that is bacteria, fungi, viruses, and parasites. These infections range from abscesses to life-threatening necrotizing infections. The key is early diagnosis and prompt management are vital in these cases. Classification of soft tissue infections. Acute. Acute conditions are cellulitis, abscesses, necrotizing fasciitis, and gas gangrene. Chronic. Actinomyces, mycetoma, tuberculosis infection. Based on the anatomical region, it can be superficial or deep infections. Based on the microbes, it can be classified into aerobic, anaerobic, mixed, and viral infections. The severity of the infections are classified into mild, moderate, and severe. The pathophysiology and the host response. The infection follows a break in the skin or the mucosa, through which the organisms multiply, releasing toxins and enzymes. This triggers the host inflammatory response and causes erythema, edema, and pain. In severe infections, if left untreated, they can also go for necrosis and sepsis. The risk is increased in immunocompromised patients, like in patients with diabetes mellitus, in elderly patients, and in patients with HIV/AIDS. So, first we'll look into the acute soft tissue infections. In acute soft tissue infections, the onset is rapid and there is severe inflammation. The common organisms that cause acute soft tissue infections are Streptococcus pyogenes, Staphylococcus aureus, and these infections mainly spread via the lymphatics and through the facial planes. The deep infections, they may infiltrate into the fascia or even the muscles. A delayed in treatment of such infections can cause necrosis and can eventually lead to systemic toxicity, and the patient may go in for sepsis. Cellulitis. Cellulitis is an acute spreading infection of the skin and the subcutaneous tissue. The most common causative organism is Streptococcus aureus and Streptococcus pyogenes. The features are the signs of inflammation again. The complications of cellulitis is the patient can go for an abscess formation, the patient can go for necrotizing fasciitis, and in turn the patient ends up in sepsis. The treatment for cellulitis is rest, elevation of the limb that is affected, and a wound culture and sensitivity test is taken, followed by which appropriate IV antibiotics is given. Erysipelas, superficial dermal infection that involves the lymphatics. The causative organism is Streptococcus pyogenes. The lesion is sharply demarcated and the margins are raised. It is commonly caused in the face and in the lower limb. The drug of choice for the treatment of erysipelas is penicillin. Necrotizing fasciitis. It is a rapidly spreading necrosis of the fascia and the subcutaneous tissue. Necrotizing fasciitis is usually polymicrobial or most commonly caused by group A streptococcus. The patient presents with severe pain, crepitus, and systemic toxicity. The treatment for this patient is urgent surgical debridement followed by wound culture and sensitivity and empirical broad spectrum antibiotics. If there is a delay in surgical debridement or the management of the patient, it has a mortality of more than 30% if the treatment is delayed. Gas gangrene. The causative organism is Clostridium perfringens and Clostridium septicem. It occurs in devitalized tissue with poor perfusion. The classical symptom the patient presents with is crepitus, foul smelling discharge, and in turn the patient will go for sepsis. The treatment is again emergency debridement of the necrotic tissue followed by antibiotics, and we give hyperbaric oxygen therapy to vitalize the tissue which has been poorly perfused. Prognosis depends on early recognition. Pyomyositis. It is a purulent infection of the skeletal muscle. The causative organism is again Streptococcus aureus. It occurs in tropical climates. Painful swelling and abscess formation usually occurs. It requires an emergency drainage followed by a appropriate IV antibiotic cover. Abscesses. First, we'll look into the types of abscesses and the features. Abscess is a localized pus collection due to a pyogenic infection. The most common site of abscesses are in the axilla, the perianal region, the scalp, and the breast. Abscesses are usually fluctuant and a tender swelling. The management of any abscess will be incision and drainage. Chronic abscesses can cause a complication known as sinus formation. The causative organism in abscesses again is Streptococcus and Staphylococcus. In gram-positive organisms, in gram-negative organisms, the causative organisms may be Pseudomonas, Klebsiella, and E. coli. And in anaerobes, it may be due to bacteroids and Clostridia. In fungal, it may be due to Candida and Aspergillus. And viral, it may be due to HPV. Anaerobic and mixed infection, it usually occurs post-traumatic or post-operative. The flora is usually mixed as the aerobes create an anaerobic condition. The symptoms is the patient, it may lead to gas formation, a foul-smelling odor, and black necrosis of the tissue. The treatment is again, it requires surgical excision of the devitalized tissue followed by metronidazole or clindamycin and delayed closure of the wound after infection control is done. Now we'll look into the transmissible viral infections. Viral infections that can affect the skin and soft tissue directly or by reactivation. The common organisms are herpes simplex virus, varicella zoster virus, a human papilloma virus, and molluscum contagiosum. The transmission is through contact, droplets, or reactivation of the virus. Usually it is self-limiting, but it may cause severe disease in case of immunocompromised patients. Some of these viral infections may mimic bacterial infections. First, we'll look into the herpes simplex virus. HSV1 is orolabial in transmission. HSV2 is genital in transmission. The transmission is by direct contact or through the secretions. Recurrent vesicular lesions on erythematous base is usually seen. The complication is eczema, herpectum, and secondary bacterial infection in the lesions. The treatment of choice, the drug used is acyclovir and vanciclovir. Varicella zoster virus. The primary infection that is caused is chickenpox. The reactivation of chickenpox in a patient who has already been affected is known as herpes zoster or shingles. It is a painful dermatomal vesicular rash and may cause post-herpetic neuralgia. The treatment is again antiretroviral drugs followed by analgesia for the pain. Human papilloma virus. They usually present in the form of warts and genital papillomas. The transmission is through a direct contact or through sexual transmission. The low risk types present with skin warts, and the high risks are oncogenic. The diagnosis is clinical and biopsy is done if it is atypical. The treatment is cryotherapy, cautery, and cautery. Molluscum contagiosum, caused by pox virus commonly in children and in immunocompromised. Transmission by direct contacts and through fomites, and the patient presents with umbilicated pearly papules. It is usually self-remitting, and again the treatment is curettage or by cryotherapy if the condition is persistent. Now we'll look into the chronic suppurative infections. Actinomycosis, chronic granulomatous infection which may cause the formation of sulfur granules. Mycetomas, a chronic fungal infection of the skin and subcutaneous tissue. The progression is slow in such infections. The patient may present with an ulcer with multiple sinuses. This requires long-term antibiotics or antifungals. Antibiotics are usually given to treat the secondary bacterial infection. Surgical excision is done if the infection is extensive. Second, now we'll look into the tuberculous soft tissue infection, secondary to spread from bone, joint, or the lymph nodes. These infections form cold abscesses and sinuses. No acute inflammation is seen, so in the sinus they won't be presenting with the signs of inflammation. The treatment is standard anti-tubercular therapy, and the excision of the residual sinus is done. Fungal and parasitic involvement. The common fungal organisms are Candida, Aspergillus that occur post-surgery or in immunocompromised patients. The common parasites that are seen in case of acute inflammatory conditions are filariasis and leishmaniasis. The patients present with a chronic induration and discharging sinuses. The diagnosis is by microscopy and culture, and the patient is treated with appropriate antifungal or antiparasitic drugs. The complication is again like any infection, the patient may go for an abscess formation, a sinus tract formation, a fistula formation, and in end stage, the tissue may go for necrosis. Systemic complications that occur in such cases are sepsis, systemic inflammatory response, and multi-organ dysfunction can occur. Functional, the patient presents with contractures, scarring, and deformity. And in case of chronic infection, it may even cause amyloidosis. The patients will have a psychological and a cosmetic impact on their physical and mental health. The investigation and imaging choices are blood tests. We go for a CBC, a CRP, and a culture. Imaging is we go for an ultrasound, an MRI, and a CT for any to identify the infections in the deeper tissues. The microbiological cultures are used to identify the organisms and to give appropriate antibiotics or antifungal drugs. Biopsy is done in case of a chronic granulomatous lesion, and a sensitivity testing is also done for appropriate antibiotic selection. The principles of acute management is the first thing is resuscitation and hemodynamic stabilization if the patient is in sepsis. We start the patient on broad spectrum IV antibiotics. A surgical drainage or a debridement is done. Supportive care is given in the form of IV fluids, nutrition, and analgesia. A regular wound dressing is done and regular bedside dressings are done, followed by regular follow-ups from the patient. And chronic infection management, we give long-term IV antibiotics or antifungals. A surgical excision of the necrotic or the fibrotic tissue is done. If reconstruction is done, if it is required, and control of comorbidities, that is if the patient has immunocompromised or diabetes, the patient has conditions like diabetes, the underlying condition is treated, and patient education is given to prevent recurrence. So the key points from today's lecture is early recognition is crucial for favorable outcome in the treatment of acute and chronic soft tissue inflammations, and we need to classify the infection based on the type and depth. Always look for the systemic involvement. We combine medical and surgical approach. Chronic infections need prolonged targeted therapy. Thank you. We'll again be back with another interesting topic.